To begin, I'd like to remind everybody to please introduce themselves every time they speak. This is Grant Ritter, the chair of the committee. And to start things off, could we take the attendance?
Yes, Mr. Chair. Tito Dolittle. Mark Schaefer.
Here.
Thank you. Matthew Brackman. Commissioner Manish Tutani from DPH. John Goin.
I'm on.
Thank you. Brendan Riff.
Present.
Thank you. Alan Skinner. And Mr. Paul Lombardo.
Here.
I believe Mr. Dolittle just joined us. Thank you. And
Thank you.
we do have a quorum, Mr. Chair.
Okay, thank you. Could I also ask the members of the staff to introduce themselves? James?
I'll jump in. I don't know if James heard you.
I'm
Oh,
here.
sorry,
I got
James.
it. I was trying to unmute myself. James Michelle, Access Health, Connecticut.
Thanks.
Hi, Susan Rich by Access Health Connecticut, Director of Legal and Governmental Affairs.
Gina Walsh, Director of Operations.
This is Glenn Jurgen, Director of Human Resources, Access Health Connecticut.
Charmaine Lawson, Plan Management.
Kelly Cody, Plan Management. Jackie Olgen, Plan Management.
Okay, thank you. Thank you very much. There's no public comment, so I guess the next thing is I'd like to have a motion to accept the minutes of the January 10th meeting from a member.
Hi, this is Stu.
Great.
Motion.
I'll second, Ted.
Ted seconds. Okay. Were there any changes, edits to make to it? If not, could I have a roll call to accept the minutes?
Grant Ritter.
Yes.
Tito Dolittle. Mr. Dolittle.
Yes, sorry.
Thank you. Mark Schaefer.
Yes.
Matthew Brackman. John Goin.
Yes.
Brendan Riff.
Yes.
Alan Skinner. And Manish Tutani. Thank you.
Great. Motion carries. Okay, now I guess I can turn this over to Kelly and Julie to discuss about follow-ups to our last meeting. Oh, wait a minute. Susan, do you want to say something about the mission and vision first?
Sure, Grant. Thank you, everybody. As we talked about at our last meeting, the board did update the mission and vision statements over the last year, working with the strategy committee. And we just always want to ground ourselves in our work for this committee in our Access Health mission and vision statements. And if you go to the next slide, Marcin. Also our values in action, those are staff adopted from the ground up, but these three really guide our work on the Access Health side, and obviously what we're doing here with this committee for the plans for consumers. Thank you.
Thank you. Okay, now we can go to the follow-ups. Kelly and Julie, take it away.
Thank you. Good afternoon, everyone. We have information for you today for follow-ups requested at our January 10th meeting. The first is regarding the value-based insurance designs. As we mentioned at our last meeting, Access Health had presented research on VBID previously to the HPBQ in 2019 that we're sharing with the committee today. We have also included a 2023 update for two of the states that participated in that national work group to design the VBID approach for the exchanges. The committee also discussed utilization for preventive services and APCD data for exchange plans. Access Health met with the APCD folks at the Office of Health Strategy to discuss future requests for the information. As a result, we are gathering the CPT codes for services that we're interested in, and we'll prepare a submission to that group this week. However, we were informed that it can take several months for the data to be pulled. Therefore, we wanted to make you aware that it's very likely that this information or data will not be made available prior to our scheduled March meeting. However, for this meeting, we did request utilization data for preventative services from Wakely through their Wakely ACA database, or otherwise known as WACA data, from the Northeast region for individual plans. So Julie Andrews of Wakely will present this information to you before the standard plan design presentation. So this slide was one of the slides that was presented back in 2019. The meeting was specifically held on February 21st of 2019, if anybody's interested in viewing that presentation. So a national work group was developed to create the VBID approach for individual exchange businesses. There was representation from many stakeholders. However, it's worthy to note that Massachusetts Health Connector and Covered California were two contributors to this work group. In June 2019, a final report was released. For your convenience, a link to that complete presentation has been included within the appendix of this presentation, and it's numbered slide 67. Could you go to the next slide, please? So this slide provides an update outlining what the Massachusetts Health Connector and Covered California have implemented to date after participating in the VBID work group. The Massachusetts Health Connector continues to permit optional value-based insurance design offerings. However, over the course of several years, they have either reduced or eliminated the cost share for the items that are listed under the Massachusetts Connector. Covered California has taken a very similar plan design approach to Connecticut by focusing on first dollar coverage and having certain benefits accessible pre-deductible. As a reminder to the group, if we review the silver standard plans that are offered through Access Health Exchange, and this is one of our plans that serves the majority of the enrollment. To date, there's about 48% of our enrollment is in a silver standard plan. That silver standard plan presently has 18 benefits or services that are available to the consumer pre-deductible for only a copay amount. And additionally, all of our plans must comply with the state mandated copay maximums for insulin, non-insulin drugs, and medically necessary diabetic supplies. So I'll stop there for a moment. Are there any questions with some of this information that I've presented? Okay. So with that said, Julie will now present the final follow-up, which is pertaining to the utilization data for preventive services. Julie?
Hello, everyone. Yes, we'll go ahead and advance to the next slide. As was mentioned, we pulled a sample of utilization of some preventive services based on a combination of some CPT or HCPCS codes with ICD-10 codes associated with preventive services for individuals that had been on the exchange for 12 months. What we found is, by using 12 months, then we could make sure that the individual would have had enough time to seek out and receive care. So the first is associated with preventive visits. And then on the next slide, is also just some screenings that often occur with those preventive visits, such as vision exams, hearing screenings, screenings for diabetes and STDs. And on the next slide is also some screenings associated with services generally provided to females, as well as colonoscopies. And for the presentations for those services most associated with females, we did limit the underlying population to females for as the denominator in the development of the analysis. And then the last preventive services screening is just again exams and services generally associated with females for their annual cancer gynecological exams. So this is just sort of some information. The percentage can vary widely and could be dependent on the chosen codes and ICD-10 combinations. So if there are no further questions on the preventive services at this time, we'll go ahead and get into looking at the standard plan designs. If we can advance to the next slide. So we did get, we don't still have final regulations from either CMS or a final federal calculator or HSA rules, but we did go out and reach out to all of the issuers and received confirmation and analysis of alternative plan options, as well as assurances that the plans as proposed meet mental health parity requirements. So if we go to the next slide, this is just a summary of what was presented at the last meeting. So no changes and not final at this time with regards to the federal regulations. And on the next slide, is just a resummary of the information regarding the proposed changes to the federal AV calculator, which is not yet finalized. And if we go ahead on to the next slide. So this is a summary of the initial analysis of the 2023 plans as they currently stand, run through the 2024 proposed federal actuarial value calculator. And as you can see in the third row of each of the two tables are a range of actuarial values, and those are the issuers, the range of issuer responses as far as their calculations. The ones in the red fonts are outside of the allowable actuarial value ranges for the metal tier as indicated. So we can see from the table that only the silver plan in the top table currently is acceptable as it stands as in the 2023 plan design. So what we've done is we've gone back to the issuers and proposed alternate plans for the gold, bronze HSA, and all the silver variants, applying a change to the maximum out of pocket. So if we go ahead and go on to the next slide. The first we're going to talk about is the gold plan. So as I mentioned, the gold plan is out of range. And so what we did was we increased or proposed an increase to the maximum out of pocket from $6,000 to $7,375. And based on that proposed out of pocket estimate, it did pass all the issuers' actuarial value calculations as well as mental health parity. At this time, we have just one option. I'll turn it back to the committee to see if there's any questions. All right. Well, then let's go ahead and move on.
Julie,
yes, go ahead.
This is Grant. I have one question. I'm just shocked that you need to raise the out-of-pocket maximum by such a large amount, because I mean, that's $1,300 increase in the out-of-pocket maximum. And yet you're only off, if as you were, by 1% with the actual value. It's 1.15% over the 82%. I just don't see how the actuarial calculator works, that it would take such a large increase in the out-of-pocket maximum to make such a small decrease in the actuarial value. It's almost like, the way I look at it is like, this could only be the case if, because it's 1%. I mean, it's like $1,000 is 1% of costs, and that means everybody's average cost is $100,000. That just doesn't make sense to me. Have you ever looked at the actual calculator and said, how much does $100 increase in out of pocket change the AVC? I'd like to see some kind of a relationship between an increase of $100 in out of pocket maximum and how much that decreases the AVC percentage, because it just floors me that you need to increase it that much. So just in the future, if you could just create a little table and say every $100 of maximum increase in out of pocket changes the AVC by 0.1% or something like that. So, I imagine there's logic to this, but it escapes me right now.
Yeah, it's sort of tied to the distribution of the services and the application of the cost sharing. So yes, we can definitely provide that detail based on a simple plan.
And interestingly, Grant, sorry, you can see here that with the testing done by Wakely and the carriers, that it came out for somebody, it came out just under, just in compliance, 81.98%.
Yep.
Even
no,
with
I know
that, with that increase. So
she's slicing it as close as she can.
as close as she can. Yeah, exactly.
I know you didn't go too far, but it just still amazes me that it took a whole $1,375 just to make such a minor drop in the AVC. So thank you.
No,
yeah,
I understand. And there may be, because I was, making an estimate, not knowing, exactly how each of the issuers would be doing their own calculations. There may be alternates or different metals where there may be more room. So why don't we go ahead and look at the silver plan options?
I think
Ted has a question.
I'm sorry, Ted. Yes, please.
Yeah. Thanks, Julie. So I think this is the first time since I've been on this committee where you have presented just one solution. What's the thinking behind that?
Well, the goal, or the direction given was to get the plan design and only attack the out of pocket. The other option, I could have gone higher and produce lower AVs. Or the other option was to have a lower maximum out of pocket, maybe touch the deductible or the cost sharing or the co-pays as well. And if that's the direction the committee would like to go, I'd be happy to put together alternate plans for the issuers to test.
And last year, Ted, I think the focus for most of the plans, I think there was maybe one that we couldn't do it in, was to only touch the maximum out of pocket as being hopefully the least impactful, negatively impactful to consumers versus touching, as Julie mentioned, the deductible. And we've just seen over the years that unfortunately just touching the individual cost shares for other items doesn't seem to move the needle as much in the calculator as the deductible and the MOOP.
Yeah, I would concur, Ted, that we tried other methods, and it turned out that the medical deductible was the other major way of doing it. And we could raise that to $1,500 instead of raising the out of pocket to, $73, $50, $75. But it just seemed like we were affecting fewer people with the latter choice. Past experience, but
no, I do understand the rationale. Thanks.
Then if there are no further questions, go ahead to the silver plans. So these are the original 2023 silver plans. The benefit categories are on the left. The next column is the standard silver plan, which, as you can see from the bottom row, has black font AV ranges, which means that that plan is fine as it stands. The 73, 87, and 94 variants do require a change in their plan design in order to become compliant. So if we go ahead and go to the next screen, we'll see the options as proposed for those plans. The silver one was increased from $7,250 to $7,475 to bring it into compliance. And the 87% plan was actually decreased from $3,000 to $2,925. And that was because actually the 3,000 originally was below for one of the issuers, below the 87% threshold. And so that's why we had to decrease it. And the other carriers maintain it in the compliant range. For the 94% plan, we increased the maximum out of pocket from $950 to $1,050, and that brought the plan into compliance. And as you can see, we're at the top of the range at 94.95 for one of the issuers. To your point, Ted, we could, as mentioned, present alternate maximum out of pockets, but, touch the deductible or the copays of some type.
Julie, is it safe to say the changes you made to the out-of-pocket maximum are much smaller in this case than the change you had to make to Gold Plan? I mean,
yes, yeah, they are different, and so the Gold plans and the Silver plans have each of their own set of data underlying them. They're specific to the plans, and so that may be the reason. One of the main drivers of why the difference in the magnitude.
Yeah.
All right, for the next one is the bronze plan. The plan as it currently stands is out of compliance, and so we increased the maximum out of pocket from the $8,800 to the $9,100, and that brought the plan into compliance. And the good news is that although the 9,100 is a significant increase, it is below actually the current maximum out of pocket allowable for 23 plans, while the proposed maximum for 24 plans is 9,450. So that provides cushion for any changes in the final proposed CMS rules. And then finally is the bronze HSA plan. To bring it into compliance, we increased the maximum out of pocket from $7,000 to $7,225, and that brought that into compliance. At this time, I have not proposed any changes to the out-of-network maximum out of pocket. You can see that for 2023, the out-of-network maximum out of pocket was 2 times the in-network one. I have not proposed that change as of yet, but that is something that can be done as well. And that out-of-network services are not a port of the actuarial value calculator, and so would not impact any of the analysis presented today. And so then that is the end of the presentation of the proposed plan designs. And I will turn it back to Dr. Ritter. if there aren't. Oh, Dr.
Sorry,
you're on
I
mute.
was on mute. Yeah, now I'd like to turn it over to Kelly to talk about the standalone dental plans, if we could.
Okay, so this slide was presented during the January 10th meeting. In summary, CMS completes an annual review of the dental services and recalculates the maximum out-of-pocket value for the standalone dental product, or SADP. For plan year 2024, as outlined on here, the value for the MOOP may not exceed $400 for one child and $800 for 2 or more children. If you could advance to the next slide. This is our current standard plan design for the SADP product. And circled in blue is our current MOOP amount, which is $350 for one child and $700 for 2 or more children. 2016 was the last time this maximum was increased. And as an additional reminder, this maximum only applies to dependent children up to age 26. So referring to CMS guidelines, this committee may consider an increase to the maximum out-of-pocket, or MOOP, for the standardized dental plan, but it cannot exceed the CMS amounts of $400 and $800. Or the committee can choose to leave this plan design as is, making no plan changes for plan year 2024. So I believe this is something that could come up for a vote today if people wanted to make that decision.
Do you have any idea what the increase in premium would be if we left it alone versus raising it, say, by $50?
I do not. That is something that we can obtain. I'm not sure if any of the actuaries have done any kind of research on that to date. If they could provide any feedback. If they can't, we can follow up with it.
I think I certainly would be interested in, if it raised it to 400 and 800, what the impact to the premium would be.
Okay.
Julie, would you have any access to data for dental plans?
Yes, I have some dental data that we could look at the impact and see what that might be.
Okay, thank you.
Yeah,
Thank you.
Kelly, this is Ted. If you know, what is the current premium? Do you happen to know?
I think, well, it ranges based on age, and obviously by carrier. So, but I think the rates are anywhere between, and it also depends on the type of product, because this is our standard plan design. So I don't know, I don't have that information in front of me, but it fluctuates depending on plan design, somewhere between high 20s into $60, depending on the level of coverage.
Yeah, I just wanted to refresh on the general ballpark. Thank you.
Yep, and Ted, we have the one standard dental plan design, and then the carriers do offer some non-standard as well. That's what Kelly's referring to. So some of the non-standard have less services included in the plan, I believe.
Yes, this would be a more rich plan.
Good.
So Ted and Grant, with your permission, maybe at the next meeting, we'll do a full analysis of we'll list all the 2023 plans and their premiums, and then we'll look at if we increase the max out of pocket from 350 to 400 and 700 to 800 respectively, and what the impact would be to premiums for 2024. So we'll do that analysis and come back at the next meeting, and hopefully we'll have a recommendation for the committee to consider.
Absolutely, that'd be wonderful. Good. Okay. Well, moving along, yeah, we're not gonna have a vote today, but
Yep.
let's have a timeline.
Sure. So there are no updates to the timeline at this point. So this slide is exactly what was presented back in early January. Once we get some of those the dates where there's TBDs, we'll certainly alert the group. If you could forward to the next slide. So proposed agendas. So our next meeting is scheduled for February 27th, which is it was originally planned to be a tentative meeting. So based on the discussions that have happened today and some of the follow-ups, I'm thinking that this might not be a tentative meeting.
It does, yeah, that does seem to be the case. We'll need that
Okay.
meeting to just go over the standard standalone dental plans, if nothing else.
Okay, so we do plan to go over the enrollment overview and obviously then go over the small or the SADP plans. And then March 13th is our next meeting after that. So that's what we have planned going forward.
And actually, just to point out that the March 13th may wind up becoming tentative, because if we do get through, all of the follow-ups on the dental and go through the plans and everybody is okay with everything, the committee could actually make a vote on February 27th on its recommendations for the board, if that works out. And if it didn't work out, then obviously we would need the March 13th meeting.
That sounds great. Of course, the actual value calculator has to be finalized by then, doesn't it? Or whatever else needs.
Yeah, I don't know. It usually doesn't get finalized by March, and it usually comes out, and Julie, correct me, sometimes it's April, sometimes it comes out much later. It's usually out after the recommendations are made. And then if something changes, we'll have to come back and make a tweak, but it usually doesn't come out till later. And then that one last item that Julie always mentions is the IRS guidance for the high deductible health plan for the HSA. That doesn't come out till later as well.
So we'll tentatively vote, and then if we need to, we can have
Exactly.
Yeah, all right.
Yep.
Okay.
Yep, but all driving towards Access Health being able to, present this committee's recommendations to the board at a special meeting in March, so that way we can have the solicitation and application finalized by the end of March. I think, Kelly, correct me if I'm wrong, for that date, because the carrier's filing deadline has been moved up to June 1st for this year, so that we give them enough time to do the work they have to do on their end.
Sounds like the sooner we get done, the sooner they can get started, right?
Exactly.
Okay, next steps. Again, Kelly.
I think next steps is we have a couple follow-ups to take care of, and we will be meeting on February 27th.
Sounds good. Yep.
Well, for the goal plan, this is two. For the goal plan, can we have a few options out there where we have the variation of deductibles on that? So we have a few options out there.
This is Julie. Would it just be the medical deductible, the pharmacy deductible, or both that you would want options considered?
Whatever option that it create a minor change instead of a big change on the maximum out of pocket. So I'm thinking about on the medical side, because it probably touch a lot more services. So try with that and see which options that create the least change. I think that's what we would like to consider.
Sure, I would be happy to, and then as well as providing the grid.
Hey, Julie.
Mm-hmm.
This is Ted. Would it be possible to give us data on how many people last year hit that maximum out of pocket?
I can provide, I do not have data for 2022. and right now I'm currently working with 2019 data because I don't feel 2020 data is very representative yet at this time. What I could do is survey the issuers and see if they would be able to provide that information. Too, I don't know what your thoughts are on that, if that would be an option. And I apologize, I don't recall Connecticut's and Gigi's representative.
Hey, Julie, this
name.
is Brandon from Connecticut.
Okay.
Yeah, we can definitely pull data and see how many people hitting. And Ted, I'm assuming you're just thinking about just that goal plan, right? You don't want like all the plan. Okay.
Yeah.
Right.
Okay. If you could also, the percentage that reached the medical deduction, it'd be good to know that ratio too. There's obviously a smaller group reached the out-of-pocket maximum, but it'd be nice to see both percentages.
Yep. Yep.
Okay. So focusing on the gold plan only, those two statistics for the standard plan version only.
Yep, that'd be great.
Okay.
Yeah.
And
I think that's
Sue
also-
and Brandon, do you all feel that you would have the 2022 data available for weekly?
It does not have run out because right now the year is just end. So that is the limitations that we have. One options that we're going to consider is 2021 data. Now we have at least 12 months run out, so we can get data for 2021.
Yeah, so I'd agree with two there. I think the deductible is going to be easier because people are going to hit that earlier in the year. The MOOP is cumulative throughout the year. And because the 22 data is incomplete, we can take a look at what we have, but it's not going to be fully mature yet.
Yeah. I think we would understand, as long as you explain the caveats.
Okay.
Okay. All right. We'll focus on 2021. That I agree. I think that makes the most sense from
That's
with
the
regards to
best,
completion.
the best choice. Yeah. Okay. Anything else? If not, I guess I could ask for a motion to adjourn.
So moved.
Okay.
I'll second that, and also thank the carriers for being willing to dig out that data for next meeting. Much appreciated.
Absolutely. Okay.
Dr. Ritter, I'm just wondering who made the motion?
That was Mark.
Mark made
Schaefer.
a motion. Ted seconded. Okay.
Thank you so much.
All right. Roll call.
Grant Ritter,
Yes.
Tito Doolittle,
Yes.
Mark Schaefer,
Yes.
Matthew Brackman, June Goen,
Yep.
Brandon Riff,
Yes.
Alan Skinner, and Commissioner Manish Tutani. Thank you.
Okay. Motion carries. Thank you, everyone. Great meeting. Short
Thanks,
and
everybody.
sweet. We'll see you next time.
Bye-bye.
Thank you all.
Thank you.
Right.
Bye-bye.
Thanks,
Good day.
everyone.
Bye now.
Bye.